mode.
Welcome to today's webinar. Today, our subject is identifying older patients at high risk of poor outcomes after joint replacement surgery. I'm just going to go through a few housekeeping items and update everyone on the competitions that are still out. And to let everybody know that the slides will be up today, as we've already gotten some questions on that. So they'll be up within 24 hours. So if you could, during this session, please send your questions in, and we will try to get to all questions before it ends. The presentation is expected to be about 30 minutes, so we have about 20 minutes for questions. At the end of this webinar, a survey will pop up on your screen to give us feedback. So hopefully you can do that to help the webinar process. We do have some upcoming webinars already posted. Now, the first one that we had originally scheduled for January 24th, I think there's 40 people signed up for that. Has to be rescheduled. So tentatively, that's now scheduled for January 31st, but we will be confirming that before the end of the week. And that's the CFN-funded Catalyst grant with Todd Campbell, Lee, and Emily McDonald on reducing post-discharge potentially inappropriate medications among the elderly. And on Wednesday, February 14th, pardon me, we have an ounce of prevention that will be presented by Ada Tang and Christina Nowak. We also have one scheduled on February 28th, the Eat Dose It study. So hopefully everyone will sign up for those. You can register on our website at any time. Currently, we have the 2018 Catalyst Grant competition out, and the intent to apply is Monday, January 15th. There are more details on our website, and you can see it on the slides there if you need more information. We also, in the December newsletter, let everyone know that our 2018 summer student program will be again held this year. And so will the CFN Interdisciplinary Fellowship Program. The SSA program, we're funding up to 10 students. We are providing funding of up to $4,000 from CFN, and we need matching funds from eligible partner organizations. The intent to apply, as I said, is due Monday, January 29th, and details are up on the website. If you have any questions, please email training@cfn-nce.ca. For the CFN Fellowship, which is a year-long, CFN will contribute up to 50% of the fellowship funding. And again, we need eligible partners for matching funds. Some of those partners will be, you will see a list of them on our website, and we'll update them as we receive any external ones that you'll be able to apply for. Currently, we have New Brunswick Health Research Foundation. The intent to apply for that is January 29th, and more details on our website. Now today we have Daniel McIsaac presenting. Just to introduce Daniel, he's an associate scientist at the Ottawa Hospital Research Institute. He's an assistant professor in the Department of Anesthesiology and Pain Medicine and Epidemiology and Public Health at the University of Ottawa. He's also an adjunct scientist at ISIS and an anesthesiologist at the Ottawa Hospital. He also is on the board of directors for the Society of Geriatric Anesthesia. So to proceed, Danielle, if you're ready, you can start your presentation, and we'll have question period after that. Thank you.
Thank you, Carol. So certainly is an honor to be here today to present our CFN work, which looked at the comparative assessment of 2 Frailty instruments to predict patient-reported disability after surgery. Now, to begin with, there are no conflicts of interest to declare, and certainly want to thank and acknowledge the Canadian Frailty Network as the major funder for this project, as well as a number of other funding bodies who've contributed both to this specific project, as well as our larger perioperative frailty research group here in Ottawa. And without a doubt, none of the work that I'm going to present today would be possible without a great group of collaborators, including clinicians, clinician scientists, and scientists, both here in Ottawa as well as around Ontario and Canada. In terms of what I'd like to cover in the next 30 to 35 minutes, I first just want to review with you the epidemiology and outcomes of older people who are having major surgery, as well as older people with frailty who are having major surgery, to really frame the importance of the research question that we've tackled. Briefly, I want to touch on what current recommendations are for frailty assessment before surgery, and then get to the meat of the matter, which is to look at the comparative accuracy of the clinical frailty scale compared to the modified Fried index in predicting new patient-reported disability after surgery. So to begin with, I'm sure there's no one on this webinar who isn't familiar with the fact that the older segment of our population is the fastest growing demographic in Canada and most other Western countries. And this chart here is basically some data from the US. Unfortunately, we don't have similar data that's been published in Canada, but the red line at the bottom shows the growth in the US population between 2000 and 2020. And then the lines above that show growth in surgical volumes across a number of major surgical specialties. And basically what this shows is, basically across all surgical specialties, the volumes are growing much faster than would be expected based on population growth. And this really is directly attributable to the fact that the population is aging. In fact, when you look at major surgical procedures like cardiac surgery, major joint replacement surgery, surgery for colorectal cancer, lung cancer, etc., well over half of patients having these big surgeries are over 65 years of age. Now, just leaving frailty off to the side for a moment, age on its own is an important predictor of bad outcomes after surgery. And when you look across studies, what you typically see is when you compare an older individual to a younger individual having the same surgery, adjusting for procedural and other patient characteristics, you tend to see a 2 to 4-fold increase in rates of morbidity, mortality, and healthcare resource use and costs, just based on advanced age. But of course, we see older patients all the time who have great outcomes after surgery. I'm an anesthesiologist. I spend half my time providing clinical care, and really almost every day I get to see patients who have surgery and get the outcome that they'd hoped for, whether it's improved survival, improved function, or quality of life. Unfortunately, though, we also see many older patients whose outcomes aren't as good, who suffer major complications, perhaps who die, or whose function may be reduced after surgery. And this certainly can't be entirely explained just by looking at chronological age, procedural risk, and comorbidity burden. And over the past 8 to 10 years, that's where we've really seen the concept of frailty emerge in our perioperative and surgical literature as a robust and important predictor of adverse outcomes. So across different frailty instruments, across different surgical specialties, we tend to see very consistent results where the presence of frailty before surgery is an independent and significant predictor of mortality, morbidity, complex hospital stays requiring ICU admissions, longer hospital stays, and loss of independence through discharge to long-term care, continuing care, etc. The effect sizes are really all over the place, and it depends on the surgical specialty, the tool that's used, but the consistent and conservative average would be, a 2 to 3-fold increase in the risk of bad outcomes. And it's also important to note that frailty is quite prevalent in most studies that look at older people having major surgery. So again, although there's variation based on the tool and the surgical population, you actually see a fairly consistent signal of about 35 to 45% of older individuals having major surgery, having frailty preoperatively. So if you think about this from a population perspective and you combine that adjusted relative risk with that population prevalence, we estimate that between 25 and 40% of adverse outcomes after major surgery in older people are attributable to frailty. So obviously a major issue for those of us who provide perioperative and surgical care, or for people involved in taking care of older people. It's also important to note that the epidemiology also seems to match up with what we suspect the mechanisms are. So if we kind of think about the biologic and physiologic premise behind frailty, where we have an older individual with potentially multiple deficits who's vulnerable to adverse health outcomes because of a loss of overall robustness, and we think about that vulnerability to stressors meeting up with the stress of having surgery. When you have surgery, we have great medications, great anesthetics, great clinicians taking care of people and good surgeons. But at the end of the day, when you come in to have surgery, you come in and you're stabbed by a knife. And that's a big stress on your body. So you have that vulnerable older person with limited reserve who meets up with that big stress of surgery, and we see that early mortality occurs. So this is a graph that shows the daily relative risk of mortality comparing an individual with preoperative frailty to an individual without preoperative frailty, adjusting for patient and procedural characteristics. And what you see is on day 3 after surgery, we have about a 30-fold increase in the risk of death for an individual with frailty. On day 7, about a 7-fold increase. And then as you get out here after the first postoperative month, we see that daily relative risk of death settle into what we expect to see in community dwelling samples of older people with frailty, 1.5 to 2 times higher. So that vulnerable individual meets up with that big stress of surgery, and certainly bad things like early mortality can happen. Of course, it's important to note that most people with frailty who have surgery don't die. Most of them survive. However, based on studies that we've done here using population-based data in Ontario, when individuals with frailty-defining diagnoses are admitted to hospital and have elective surgery, and they've come from the community, they aren't in a long-term care facility or anything like that beforehand, they are far more likely to require discharge to a non-home location. So again, adjusting for a robust set of confounders, about a 3 to 5-fold increase in that risk, and the absolute incidence is between 30 and 50%. So a large proportion of individuals with frailty-defining diagnoses before surgery who have elective major surgery are not discharged back home. So to summarize the epidemiology and how we understand it right now, older people have surgery very commonly, and frailty is quite prevalent within these populations. When frailty is present, we see a significant increase in the risk of adverse outcomes, and this is consistent across surgical specialties as well as frailty instruments. So this leads to the question, what do we do about this? And this is a real knowledge gap in the literature right now, because we've got lots and lots of papers that show that frailty instrument X predicts bad outcome Y, but we haven't seen a big progression towards doing something about that. And to start to tackle how we might do something about that, I want to just briefly introduce you to how things work when it comes to providing perioperative care. So for those of you who don't provide perioperative or surgical care, typically we break this episode of care down into 3 phases: a preoperative phase, an intraoperative phase, and a postoperative phase. The preoperative phase really starts when an individual is diagnosed with a condition that may require surgery. They'll be evaluated, undergo a decision-making process as to whether they'll go forward with surgery or not. And if we're going to go ahead and do surgery, obviously we start to put a care plan together and hopefully get a chance to optimize that individual before they come in for surgery. When they come into hospital to have surgery, the intraoperative phase, an anesthesiologist like myself provides them with anesthesia. A surgeon does the surgery, and we start to get on top of things like acute pain management and appropriate acute monitoring. As they transition out of that operative phase, intraoperative phase, and into the postoperative phase, we're looking at continuing the acute to chronic pain management transition, getting into the recovery and rehabilitation phase, and then hopefully supporting that individual as they transition back to the community, preferably having obviously achieved the good outcome that they had looked for. So when we sat down after reviewing the epidemiology, we thought to try and tackle this problem, we really need to go right back to the beginning. And we need to be able to tackle the evaluation piece so that we can consistently and accurately identify older individuals who have frailty before surgery, so we can try and address the adverse outcome burden. And a few of the questions that start to emerge here are, what instrument? In perioperative frailty, like in most areas of frailty research, there are hundreds of instruments that have either been tested in multiple studies or made de novo. And what outcome do we use to try and define that the instrument is the right one to use? And of course, once we've gone through that phase, how do we then implement that into routine care? Presentation today is mostly going to focus on those first 2 points. However, there will be a few comments on implementation as we get into the end of the presentation. So in terms of the challenges, as I said, got to choose the frailty instruments. The perioperative literature to date really focuses on the typical outcomes that you see in databases: length of stay, complications, mortality, etc. Really, there are almost no patient-reported or functional outcomes out there. And we're also dealing with a very well-defined part of the healthcare system, which, like most areas, is time and resource limited. So we have bench lines in Ontario in terms of how quickly we need to get patients, from diagnosis to the operating room, in terms of how soon we need to see them before surgery. So all of this frailty evaluation either has to fit into the existing healthcare system, or we need to be able to prove a case where this needs to change to allow us to support the best outcomes moving forward. So what tool should we use? Well, actually, the first part of this is fairly straightforward. In 2012, the American Geriatric Society and the American College of Surgeons put out a best practice guideline for the optimal preoperative assessment of the geriatric surgical patient. And one of the main recommendations was that frailty be evaluated, and they suggested using the modified Freed index. At that time, probably the best studied frailty instrument within surgical literature. And for those of you who aren't familiar with it, this is a phenotype frailty instrument initially from the cardiovascular study of health and aging, which combines a 5-point scale. So there's a patient-reported low activity, patient-reported unintentional weight loss, patient-reported history of falls, and then physiologic measurements of grip strength and gait speed. And although different cutoffs appear in the literature, typically one would say if there's a score of 3 or higher, an individual is defined as having frailty. But that's one. There are obviously hundreds of other frailty tools out there. What should we compare it to? It'd be nice to compare it to all of the relevant ones, but obviously that's not feasible or practical. So again, we reviewed the acute care literature, we spoke to experts, we spoke to colleagues, and we decided we compare it to the clinical frailty scale. The reason being that it was well validated at that point and continues to be in acute care settings, particularly in ICU, but also in emergency medicine, as well as acute internal medicine. It has good inter-rater reliability, and in particular between different types of clinician specialists. And a number of different types of clinician specialists tend to evaluate patients before surgery. And in terms of predicting mortality, has shown similar prognostic accuracy to large frailty indices, 30, 60, or 80 variable indices. It's also one, as you can see here, that looks fairly friendly. It's vignette-based, and people tend to like using it. So we made a pragmatic decision to make this comparison. Now that we choose our 2 comparator tools, though, we needed to decide what outcome was going to define which one was better. And as I mentioned earlier, the morbidity, mortality, length of stay type outcomes are very well reported. So we saw this as an opportunity to bridge the gap between the traditional outcomes and the lack of patient-reported and functional outcomes in the literature within a large study. So we wanted to find an appropriate patient-reported outcome to use in this setting. Again, we went to the literature, we reviewed it, we talked to experts, and we wanted to identify a tool that was available, preferably free of licensing fees, that was validated, and that really made sense. So fully admit, when we were bringing our Catalyst grant together several years ago, I was a new investigator, a very new investigator at that time, and didn't probably have the time or knowledge of how to bring a patient advisory council together to choose the best tool. But based on a number of pragmatic points, we chose the World Health Organization Disability Assessment Schedule version 2. For those of you who aren't familiar with it, it brings together a lot of really practical domains into a disability assessment. So as you can see, they're very practical things, function-wise, ability to stand, your ability to walk, your ability to get dressed. There are day-to-day tasks like taking care of your household responsibilities, doing your day-to-day tasks or work, as well as kind of emotional and psychological things, such as learning new tasks, maintaining engagement in your community, your emotional side of things and concentration, as well as dealing with new people and friendships. And these different domains are all assessed either in person by the patient or through a validated telephone version. And they are put onto a 100-point scale, which has an established 8-point minimally important clinical difference and an established cut point of 25 points to define disability. Or if an individual had pre-existing disability, so a disability score of 25 or higher, an increase from baseline of 8 points would be considered a significant new disability. Importantly, it's also been validated psychometrically in surgical care, as well as in many other acute and chronic conditions. So this was our patient-reported outcome. Having put these pieces together, we then moved forward to tackle our formal research question, which was in a population of people 65 years or older who are having major elective non-cardiac surgery. And as you saw from the title, this did start out initially focused just on joint replacement, but we did open it up to all major elective non-cardiac surgeries after starting recruitment. The exposure was preoperative frailty and comparing the clinical frailty scale to the modified Freed index, and the primary outcome was patient-reported new disability or death 90 days after surgery. The secondary outcomes came down to practical things. Was it feasible for use in the preoperative clinic? Was it acceptable for use in the preoperative clinic? And then the traditional outcomes like complications, length of stay, etc. The design was a multi-center prospective cohort study between 2 academic health sciences centers and a community hospital in Ottawa. And the basic setup of how the study ran was that at the preoperative clinic visit, which typically happens 7 to 28 days before surgery, frailty status was established based on the clinical frailty scale and the modified Freed index by a trained research assistant, and each frailty assessment was then also reviewed by a study clinician. The baseline disability score was established, and then baseline covariate data, which basically incorporated all of the assessment points of the American College of Surgeons and American Geriatric Society best practice guideline, were also collected, and they'd be the typical things that you'd see in table 1 of a study, but did include issues around mood and anxiety, substance use, and cognitive screening. At the time of surgery, when people came into hospital, we used validated administrative data sources to get hospital length of stay. We have a validated measure of administrative data complications, and we established their individual's discharge disposition, and we also did a chart review to confirm complications. 30-day follow-up was by phone, in which case we established whether the individual was still alive. If so, we got their baseline, their 30-day disability score, and did a screen for new anxiety or depression. 90-day follow-up was the primary outcome window. So again, we established their survival status, got their disability score, did the anxiety depression screen, and asked a question around decisional regret as to whether people were happy that they'd proceeded with the surgery that they'd had. 90-day follow-up is complete, so I'm going to present to you complete follow-up data at the primary outcome today. 365-day follow-up is not quite completed, but at that point, again, all the same points were taken, and we've also will link our data set to administrative data at the Institute for Clinical Evaluative Sciences to get a record of health resource use over the year after surgery for our enrolled patients. Now, I mentioned earlier, most of the time when we have studies in our literature in perioperative frailty, but I mean it's pretty consistent across most frailty studies, we have frailty instrument X predicts bad outcome Y. And although that's useful because it's going to generate an effect estimate like a risk ratio or an odds ratio for you, it doesn't make it very easy to compare two tools, and there's also a lot of information missing. It doesn't really give you a sense of how prevalent the outcome or the exposure are, and it doesn't necessarily reflect why we want to identify frailty before surgery, which is to try and improve outcomes. So we recognize that this is actually going to be primarily more of a question of diagnostic accuracy or screening. So if we identify an individual who has frailty before surgery, will they go on to experience a new disability, a bad outcome after surgery? Therefore, we can try and do things to optimize the individual or the healthcare system to decrease the likelihood of that happening, or help them make a decision more consistent with their values. So the primary analysis that we determined we needed to do based on a discussion with our biostatistical collaborators was something that most people probably aren't super familiar with, but their measures called the relative true positive rate and the relative false positive rate. But very simply put, the relative true positive rate is just the ratio of the sensitivities between the two tests. So how good is the test, the frailty instrument, when it identifies an individual as having frailty, of identifying that individual with frailty who goes on to have a new disability or die after surgery? Of course, if a tool was labeled everyone as being frail, it would capture every bad outcome after surgery. So there needs to be a balance there. And the relative false positive rate provides that balance. And this is just a ratio of the number of false positives between tests, i.e. how often when an individual was identified as being frail before surgery, did they go on and have an outcome that did not involve death or experiencing a new disability. So basically just a ratio of sensitivities and a comparative ratio of false positives to give a sense of its overall diagnostic accuracy. The sample size for this, based on the literature, there's not a lot out there on postoperative disability, but we estimated based on what was available, there might be 18%. The sensitivity of the modified Fried index for predicting complications after surgery is about 60%. So we determined we'd need about 648 participants to have 80% power at a 5% significance level to determine a 30% difference in relative true positive rates between tests. And we decided to recruit 700 total patients to allow for the potential of 15% loss at follow-up. Also important to note here that to do these diagnostic accuracy type tests, we need to have a binary or dichotomized measures, and a priori from day one, we said we'd use the cutoff of clinical frailty scale 4 or higher and modified Fried index of 3 or higher, so to ensure that no one would think that we've changed that cutoff point to get the best results. These are all a priori specified in our protocol and published in our protocol. We also included effect sizes, odds ratios, risk ratios, and absolute risk differences, and did a receiver operating curve analyses to look at the discrimination between tests, which is probably more common comparative analysis that we see when looking at comparisons between frailty instruments. So, what we've all been waiting for, what did we find? Well, we enrolled 705 individuals who went on to have their planned surgery, and this is always an issue when you're doing surgical studies. You recruit someone, and for different reasons, they may not end up actually having their surgery. So that's why we ended up with a little over the number of patients we planned on recruiting. At 30 days, we were able to get 96% complete outcome data, and then at our primary outcome, we were able to get 93% complete data for disability and survival follow-up. The cohort had a mean age of 73 years, 49% of them were female, and the median comorbidity score on the Elix-Hauser scale was 2, so multimorbidity was present in your average patient. In terms of the surgical specialties, a little under half of individuals had orthopedic surgery, and then there's a mixture of other non-cardiac surgeries. This is pretty representative of what elective non-cardiac surgery looks like in Ontario. 40 to 50% orthopedic, and then different amounts of vascular, thoracic, and general surgery. So fairly representative of how we do things in our province. The prevalence of frailty based on the clinical frailty cutoff of 4 higher was 42%, and with the MFI it was 37%, which is consistent with that 35 to 45% estimate that we spoke about earlier. And in case people are interested, there was moderate agreement with a gap of 0.5 between the two frailty instruments. In terms of the primary outcome, at 90 days, 10 patients died, so that's a mortality rate of 1.5%, again, fairly consistent with what you'd expect to see in populations of older individuals having these major surgeries. And 11.1% either died or experienced a new disability, which was slightly lower than what we had expected based on the available literature. So for individuals who are identified as having frailty with the clinical frailty scale, 15.5% experienced death or new disability compared to 7.9% of those who did not have frailty. And that was very similar when the MFI was used, as you can see. So we got a twofold difference for both frailty instruments. Getting into how accurate of a test, the sensitivity and specificity of the CFS was close to 60% for each. And for the modified Fried index, sensitivity was slightly lower and specificity was slightly higher. However, whenever we calculated these relative true positive rates, statistically, there was no difference in sensitivity between the two tests, nor was there any difference in false positive rates between the two tests. So the null value for each of these rates is 1, and 1 is within the 95% confidence interval of each outcome. So when it comes to the big picture, the accuracy of each of these tools in predicting an individual with frailty who will go on to experience new disability or death after surgery was equivalent. In terms of the effect sizes, and I'll note this is adjusted for surgical procedure, for a clinical frailty scale over 4, the adjusted odds ratio was 2.51, which was statistically significant, as was the MFI with an odds ratio of 2.6. Again, fairly consistent with what you'd see for the adverse outcome association with frailty in most surgical studies. In terms of discrimination, the area under the receiver operating curve was not particularly high for either test, and when compared, they were not statistically significantly different in terms of predicting the incidence of death or new disability after surgery. One of the things that we built into this, and I think this is one of the most interesting findings for me, is that we had disability scores taken at multiple time points, which allowed us to reconstruct a disability trajectory around the time of surgery and after the time of surgery. And what we see is, not surprisingly, before surgery, individuals with frailty were more disabled, and this is based on the CFS, or the results are almost the same with the MFI. So, not surprising, disability and frailty are related but distinct concepts. Higher rate of disability in individuals with frailty before surgery. At day 30, there was a slight increase in disability scores in both groups. Again, not surprising, people are healing up from having, a big surgical incision, having had a big procedure. But when we get to day 90, the trajectory shapes look fairly similar. In fact, both groups, on average, have experienced a net decrease in their disability scores. So, on average, from a disability perspective, both groups have benefited from having surgery potentially. And when we looked at a mixed model repeated measures analysis, what we actually found was that individuals with frailty before surgery were likely to experience a greater net decrease in disability than were people who did not have frailty before surgery. So when I've spoken to colleagues and given talks in the past, people often want to hear that, okay, an individual has frailty before surgery, that just means we shouldn't operate. Based on these data where we have patient-reported outcomes and functional data, it suggests that although adverse outcome rates are higher in individuals with frailty, on average, there's an opportunity to benefit disability-wise from having surgery. So just because someone has frailty before surgery by no means is a reason to not proceed with surgery. In fact, there's a likely benefit potentially to be experienced there. So at this point, we've determined that neither tool outperformed the other in terms of its prognostic accuracy. There's a potential benefit in disability terms to individuals with frailty going ahead and having surgery. So what tool should we consider using in clinic if we're going to consider one of these two tools? We pre-specified that we looked at feasibility, and the time to administer the clinical frailty scale was 42 seconds compared to 300 seconds or 5 minutes for the modified Freed index, so a 7-fold difference there. And I can tell you as a clinician, if I told my colleagues, let's do this new assessment, it'll take you less than a minute, and it could help with risk stratification and patient decision making, they'd say no problem. If I told them it was going to take 5 minutes, they'd say no way. So that's, I think, a clinically significant difference. Also, we had complete data on the CFS on all patients. However, for 17% of patients, they did not want to give data on at least one part of the modified Freed index. Some didn't want to fill out the activity questionnaire, some didn't want to do walking tests, some didn't want to do grip strength. So in almost 1 in 5 individuals, they did not want to complete one component of the modified Freed index. In terms of acceptability, we used a modified clinical decision tool acceptability scale. It was a 5-point Likert scale. So what I'm showing you here are the proportion of people who scored 4 or 5. And for the CFS, 90% of clinicians found it was either very or extremely easy to use, very or extremely useful in practice, and 70%. Beneficial to care, lower. I'm going to comment on that a little later. And then easy to use logistically, 94% felt that it was either very or extremely easy to use logistically, which I think makes sense given how the tool is used. As you can see, for the modified Freed index, those scores were a lot lower. No big difference in terms of the beneficial to care, but people found it took a lot of time. It requires, if you're going to do it the way that it's described in the derivation paper, a $700 hand grip strength analyzer, and it just takes a lot more logistically to do modified Freed indexes compared to applying a clinical frailty scale. We also asked patients just a general question, because obviously we need to have the patient perspective, whether they were willing on the same 5-point scale to undergo frailty assessment for future surgery if it might help benefit their care. And 71% were either very or extremely willing to participate, and actually only 0.5% were either very or extremely unwilling to participate. So generally speaking, most patients are more than happy to participate in frailty assessment before surgery with the idea it may help things as we move forward. So in summary, in terms of what we found in this study, we found no significant difference between these two tools in terms of sensitivity, false positive rates, or discrimination. However, based on the feasibility and acceptability, we would say that the CFS is probably superior for clinical use in this setting. In terms of disability trajectories from perioperative frailty, or for preoperative frailty, people with frailty before surgery may benefit from a disability perspective having surgery even more than people without preoperative frailty. So just to wrap things up, we've now evaluated a couple leading tools. We've gotten some accuracy, feasibility, and acceptability data on them. How do we move this forward? Well, we'd like to get routine frailty assessment in place in hospitals in Ontario, Canada, and elsewhere, and this is not well described in the literature. So we've actually moved forward and started doing some qualitative work using the theoretical domains framework with anesthesiologists, surgeons, and preoperative nurses to identify what the barriers and facilitators to preoperative frailty assessment might be. And what we've identified with our preliminary results is pretty favorable. So generally speaking, these clinicians are familiar with the concept of frailty, but not surprisingly aren't particularly well able to define it. They do understand that it has a large impact on outcomes, and they generally feel that it's appropriate for their professional role to screen for frailty before surgery. They have a general belief it should be easy to perform, given the tools that they've been exposed to, and they think it's an important goal to get frailty assessment put into preoperative care. So I think we have a promising, good, positive substrate to help move this knowledge forward. Once we can routinely identify people with frailty before surgery, we then need to start having interventions to try and improve outcomes, improve decision making, etc. We've recently published a systematic review which looked to identify and review interventions to improve outcomes for frail people, older people with frailty having surgery. And the results are mixed. You're only able to actually identify 11 studies and very few registered protocols where there was a defined population of individuals with frailty who were having surgery and an intervention was applied to improve their outcomes. Of these studies, all of them were moderate to high risk of bias. Only 6 of them are randomized trials. So not many there and the quality not great. However, there was some consistent findings around exercise, whether applied pre or post-operatively. It looks promising in terms of improving both patient-centered and system-centered outcomes. However, given what's available, well-powered and low risk of bias studies are needed of perioperative exercise for older individuals with frailty. And we're fortunate that we're about 50 patients into a 200-patient parallel arm RCT, looking to provide individuals with frailty before major cancer surgery with a structured home-based exercise program compared to standard care, looking to improve functional outcomes after surgery. And as of this week, it's already the largest trial of preoperative exercise in people with frailty. So we look forward in a year or two to presenting those results to interested folks. So in summary, this is the final summary. Frailty is prevalent before major surgery, and it's associated with increased rates of new disability. When looking to identify frailty before surgery, the clinical frailty scale is prognostically equivalent to the guideline recommended modified Fried index and appears to be more feasible and acceptable than the modified Fried index for preoperative use. Having frailty before surgery does not appear to preclude the ability to benefit from a disability perspective from surgery. In fact, there may be more benefit to gain there given the high disability scores before surgery. But interventions specifically designed for people with frailty having surgery urgently need to be designed, tested, and then if effective, implemented. And we'd be very interested to identify anybody out there who's interested in testing and designing more of these types of interventions. So in summary, I need to thank the research team that we have in Ottawa who has done most of the data collection for the studies I presented today. They're already well into the exercise studies, so they always tend to provide some action shots as well. But really, between Emily, Chelsea, Aaron, and Kristen, they do the hard work on this stuff, and they're excellent with patients. We need to thank them. And then Corley Wong, who's been a great analyst working with us. Thank you very much.
Thank you, Daniel, for your informative presentation. We've actually received some comments already through our questions about how informative your presentation is, and to thank you, and that they have really no questions for you. So, but we do have a few other questions that are coming in now, once I've just said that. So just to the audience, please continue to send in your questions and we'll try to get to as many as possible. We have about 10 or 15 minutes. So the first question is, even though you observed a statistically significant effective improvement of 8 points in disability score for the frail patients after the 90-day period, how clinically significant is the 8-point decrease?
So, interestingly, on the HUDAS scale, the minimally important clinical difference that's been established on that scale is 8 points. So, just coincidentally, that it does appear to be a clinically significant difference based on the psychometrics of that particular test. That's about the extent to which I can comment on that. Obviously, individuals with frailty had a much higher disability score at baseline, and therefore it may be easier to, there's more gain to potentially get there. But at the same time, older people with frailty also experience higher rates of new disability. So this has really got us thinking about, how do we identify and stratify and appropriately care for the stratum of older people with frailty who do go on to experience the adverse outcome of getting new disability, while continuing to encourage and optimize the disability benefit that on average is seen across the population. So again, this is a study that has dichotomized those frailty scales, but we obviously need to look at this probably in more granular detail, both in the data we have here and I think other data that needs to be collected in the future to try and really differentiate how do we target specifically those individuals who do go on to have the new disability, because we do see an overall net benefit of disability decrease. And it's not just in people having knee replacements, but it's also in people having vascular surgery and general surgery too. So it's an important question that we still are trying to tackle, and anyone who has insights, I'd love to hear them.
Yeah, certainly more to do in this area for sure. And kind of further to that, another question's come up in terms of, well, it keeps moving. Was the length of wait for the surgery taken into account? And if so, did it have any effect on the outcomes?
Well, that's a very good question. Almost no patients in our cohort had a baseline assessment, so frailty and disability scores, more than 1 month before surgery. So I must admit, I have not gone through to do sensitivity analyses yet, looking at the number of days that the baseline and frailty scores were taken to surgery. I suspect that if there was a much longer period than 1 month, we'd probably see some differences. There are lots of patients that I see in pre-op clinic a month or 3 weeks before surgery, and then I see them again in the operating room to provide anesthesia care, and there typically hasn't been a big change. Sometimes in cancer patients, we actually see a decrease in function over that time as people start to deal with the fact that they've had a recent diagnosis of cancer. But overall, I think we probably would see no real effect based on the lag time between the baseline measurement and the surgery date, just because they were relatively proximal in time for everyone.
Okay. There's quite a few questions now coming in, and here's a unique one. Can you elaborate on why only 46% of clinicians found the tools beneficial to care?
Yeah, I meant to comment on that a little bit further, and I appreciate the opportunity to do that. I think it comes down to the last few slides that I went over in the presentation. Clinicians, and certainly in preoperative medicine, we get bombarded with all kinds of risk stratification tools, cardiac risk stratification tools, pain risk stratification tools, frailty risk stratification tools. And there's understandably a lot of, so what? Great, we can identify someone as being high risk for whatever reason and for whatever outcome, but what are we supposed to do about it? We're fortunate, I think we have a very good perioperative healthcare system in Ontario and in Canada, well-trained individuals, and generally we get, working with our patients, good outcomes from surgery. But I think this needs to move to see people see the value in frailty assessment before surgery, and I've heard this from lots of colleagues, it needs to be linked up to something. So what are we going to do about this? And I think that's why for the modified Fried index and the CFS, we saw very similar scores, I think 46% and 44%, because regardless of how you define frailty, people want to know what you're going to do about it. And we're obviously testing some exercise interventions, and we have some other interventions in the works right now. But until we can show that there are things that we can do and clinicians can engage in to improve outcomes and work with their patients, of course there's going to be a so what about risk stratification, because risk stratification, from my perspective, is probably only worthwhile if it's attached to an actionable item.
Okay. Here's another good question is, how do you reconcile the benefit in the frail population with the cancellation rate chosen by the very frail in Paige Moorhouse's work with PATH? Paige's work in Nova Scotia?
Paige's work. So I think, if I'm understanding the question correctly, I think what probably would be useful would be to look at kind of the distribution of frailty scores between the two tools in our population. And as you can see, when you get up into the higher ranks of the clinical frailty scale and into the 4s and 5s in the modified Fried index, we actually have very few patients who are severely frail who are having surgery. So there are some studies out there. There was one published in JAMA Surgery earlier in 2017, which looked at using a RAI assessment of frailty to identify individuals who were severely frail, and then basically telling everyone on the perioperative team that they were severely frail. It was a methodologically limited before-after study, but it did show improvements in hospital outcomes after the implementation of identification of severely frail patients before surgery or individuals. So I guess what I'd say is, generally speaking, we are not doing elective surgery on a lot of individuals with severe frailty. So I think this is part of what I was kind of alluding to earlier, and I apologize I wasn't super clear about it. We see kind of these divergent findings from this study. We see at a cohort level an overall decrease in disability amongst individuals with frailty to a greater degree than that experienced by people who didn't have frailty before surgery. But at the same time, we see an increase in the number of people who experience new disability or die after surgery. So I think we need to get into a system where we can identify, and obviously we need to grade greater than a binary frailty tool, and identify those who are severely frail, and the path type program may be the most appropriate there, where we really need to bear down and really go through the nuts and bolts of the decision as to whether to proceed or whether there's a less invasive surgical procedure that might achieve similar outcomes. And then for those individuals who maybe have more of a moderate frailty state, maybe there's more work that needs to be done there. Sure, let's go ahead and do surgery, but let's work on optimization in an appropriate time scale, potentially around exercise, potentially around other interventions, improved care pathways, etc. But I think that the big thing is that we don't do a lot of elective surgery on severely frail individuals. That's probably reasonable, but we do some, and we probably need to do a better job there around decision-making, value mapping, and that kind of thing. And I think Paige's program is a really good example of that, and the effect that can have on surgical decision-making amongst older people considering an invasive procedure.
Yeah, it is very interesting too, because the approaches across different provinces seem to vary, and different people are working on different tools, and some of their studies aren't finished yet. Here's a question, and I'm not sure if you would have an answer to this one, but it's asking if you would have a patient-reported frailty scale assessment tool that you would recommend when you have phone assessments.
Mm-hmm. So we actually asked patients in our study to rate themselves on the clinical frailty scale and to tell us if they liked that. They were all very happy to do it. They found that they could slot themselves in comfortably looking at the scale. We just had basically a laminated version of it that we could wipe down. And this was in clinic, it wasn't over the phone. And our research assistants asked them to take a look at it and tell us what they thought their clinical frailty scale was. I don't have the specific final analysis data on that, but I can tell you when I looked at the preliminary analysis after we completed 30-day follow-up, after we completed 500 patient follow-up, pretty consistently individuals rated their frailty one rank lower on the CFS than their clinical assessment. So they seem to be able to do it consistently. They seem to be comfortable doing it. It's just that where they placed themselves was a little lower on the frailty scale than where the clinicians placed them. So I don't have a perfect answer for you. I certainly don't have an answer. I know that there are a few tools out there that have been looked at for phone assessment for frailty. However, for us, patients seem pretty happy to use the CFS. They just rank themselves as being one score on average less frail than clinicians did.
Okay. I see that we're closely running out of time, and I think we have one or two questions left, but I'm wondering if it's time for maybe you to summarize or give us your latest thoughts or last thoughts before we end today's webinar.
I'd be happy to. I apologize if I was long-winded on some of my answers and we didn't get to as many, but please feel free to email me if you have specific questions and I'll try to get back to you.
So that's great, because we do have your email that we could send out as well, right?
Yeah, no, that'd be fine.
Okay, thanks.
So I think in summary, we've looked at 2 frailty instruments. I think they were 2 reasonable frailty instruments to look at for clinical use. But I think an argument could be made that perhaps there are other frailty instruments that we need to look at, and perhaps we need to come to some agreement on what types of frailty instruments we should be looking at, so that we can nail that first part, at least in perioperative care, of what tool are we going to use, and then how are we going to implement it more widely, because this is obviously very important. The second take home would be that we have this divergence of outcomes between older individuals with frailty, both potentially benefiting more as a population, but as individuals experiencing more disability after surgery, and we need to start to do things to tackle and reconcile that. And I think that leads into the third point, which is once we've identified the presence of frailty as a risk stratification variable before surgery, what are we going to do about it. And I think that deserves some important attention, especially given the fact that we have some patient-reported outcome data here to suggest that overall there may be a benefit of proceeding with surgery amongst individuals as a population who have frailty before surgery, but we really need to tackle, and I think in patient-meaningful and methodologically robust ways, specific interventions or well-planned complex bundles of interventions. I can tell you in our systematic review, there were a number of multi-component kind of geriatric specific protocols that were tested, and the results were all over the place because they included everything but the kitchen sink and were methodologically robust in their composition, implementation, or analysis. So we're going to use patients' time and resources to test these things. We should have a commitment to doing that really well. And I'm sure most people on this call would agree with that. So I appreciate everyone's joining the webinar today, and I appreciate the great questions. Please feel free to reach out, whether it's for questions based on today's presentation or opportunities that might arise to work together to try and improve the outcomes of older people with frailty who are considering having surgery.
Thank you, Danielle. And it sounds like you already have a bunch of plans in place that you would, or opportunities to continue this. So that's good. And we will forward some of the questions to you so that you can address them. And just if everyone could take a moment to complete the pop-up survey today, it gives us an opportunity to improve webinars in the future, and it also gives an opportunity to give feedback to Daniel, and we pass that along to him. And I think if you could go to our website, we have a list of upcoming webinars, and feel free to register for them. Like I said, there's one in question right now, and we'll have that up in the next week. So again, thanks to everybody for joining today, and especially to you, Danielle, for doing the presentation and having a good Q&A today. So basically that ends today's webinar. I hope everybody has a great rest of the day. Thank you so much for joining. Bye-bye.